Thank you. And our next speaker is about how to combine multi-specialties in a vascular, endovascular by Dr. Aburahma.
Thank you, Munir. There's nothing to disclose here. Vascular surgeons are a relative minority in the crowded field of specialists who treat vascular disease. But I'm sure all of you agree that vascular surgery is only specialty exclusive devoted to diagnosis and treatment of the vascular disease. Not only that, but we believe that we are the only specialists who provide the entire spectrum of treatment, whether medical, open, or endo. And of course, I'm biased, the vascular surgery board in the United States, at least in the Western world and United States, is considered to be the definitive measure of the vascular surgeon expertise in this management. Workforce shortages and maldistribution to create access issues to vascular surgeons, and that's expected, I presume, in many parts in the world. Advances in the treatment and device technology made treatment of a significant number of vascular conditions within the perceived scope of their specialties, and perhaps many of them without adequate training. The current payment policy in the United States and incentives reward the wrong behavior. What happened then? Quality challenge, increased complications, landing in many times in the vascular surgery practice, which means we see a lot of these complicated issues. Payment inefficiency means overutilizations and unnecessary procedures. However, I'm sure everybody in this room, which I believe most of you are vascular surgeons, I've given this talk to other people in America many times, non-vascular surgeon. I think all of us have a common goal, which is optimizing care for vascular patients. I'm going to skip a couple of slides because of the sake of time. That I'm trying to share with you some of the providers who provide these procedures. Let me give an example. Total number of linked AAA procedure in 2014 through 2016 from the Vascular Quality Initiative. Look into the numbers. Vascular surgeon did literally 82%. Radiology did 5%. Cardiac is 3.2%. That's for EVAR. When it comes to open procedures, vascular surgeon literally did the most, which is over 80%. I thought also to put the data on atherectomy, which is relatively common in America, just to show you how this distribution is. If you look to the non-high volume for atherectomies, close to 48% done by vascular surgeons, 1/3 done by cardiology. When you look to high user of atherectomies, vascular surgeon and cardiologist was almost similar, except a little bit more for cardiology, which means one of two options. Either a lot of these are done unnecessarily by non-vascular providers, or something else which I don't want to comment. It looked like I have a duplicate of slide that, again, similar to what happened to me earlier. I have slide on the right and slide on the left. Okay, so I already covered that atherectomy. That's better. Thank you. I think you guys don't like me, do you? Okay, I could speak Egyptian if you want to. Okay, next one is here. Now, look into more recent data on the EVAR. That's a much larger data. EVAR is done by roughly 57% of vascular surgeons. Radiology in America is roughly 7%, but still cardiology does 6% of it. But again, for open procedures, still we do a good bulk of it, around 57%, cardiac surgeon around 18%, and in America, general surgeon does roughly 12%. When it comes to carotid endarterectomy, still we are the most dominant, half of it done by vascular surgeon, but look at the bottom for carotid stenting. We do roughly 1/4, but look under cardiology, literally half of it done by our cardiology colleague in the United States. That's important to us, ladies and gentlemen. Look at this slide. Younger vascular surgeon, like most of you, defined below 50 years old, reported that 90% of their practice today were endovascular, while older vascular surgeons like myself reported that, look at this, 2/3 of their practice is now endovascular procedures. I'm going to share this slide with you to show you why this issue has to be addressed. Treatment for claudicant, this is published at the JVS just by a past president of the SPS, Dr. Peter Lawrence, between 2004 and 2017. Look at the bottom of it. 1/3 of patients were free from recurrent symptoms at 2 years. Only 1/3. And many lack preoperative procedure optimization for medical management. Look at the bottom one also. Use of atherectomy and treatment of more than 2 arteries in claudicant were associated with a miserable outcome. And that I don't want to go through. I heard something yesterday about claudicant, which I'm going to tell you, but I felt to be out of politics. The concept of multispecialty, which I'm supposed to be addressing you today in vascular surgery, existed since World War II. Organized cardiovascular center in the United States existed in 1980s. The service line strategy involving multiple specialties can be a challenge in any medical center. Vascular disease, as you know, can be managed by vascular surgeons, vascular medicine, interventional radiology, and cardiologists. You don't believe this till I looked at it over 2 years ago. The War Department of the United States purchased a place in West Virginia, which is the Greenbrier, which I showed you earlier today, on September 4th in 1942 for only $3 million. Converted the hotel to 2,000-bed hospital focusing on vascular surgery, and many people believe it was the first vascular center of excellence and neurological issues in soldiers. They talk about 8 years ago. In 4 years, over 24,000 soldiers were treated in West Virginia, my home state. And that's what the place looked like in 1940 at the era of World War II. And that's what it looked today. The one I told you earlier, this Dr. Aburahma's White House. This is called the Resort of the America because it's no longer a hospital. The vascular center at the Greenbrier at that time treated so many vascular entities. It was considered to be the center of vascular innovation in neurosurgical technique and treatment of aneurysms, fistulas, post-traumatic ischemia, initially started by you guys, surgeons, then added internal medicine specialists to treat other disorders, as you see here. And the first publication in the English literature about vascular entities came in 1940s, as you see in this report from the Ashford Hospital, again, the Greenbrier. And that's what the hospital looked like then in 1940s. And now, fast forward 50 years later, in 1994, the concept of our modern vascular center was born. And I'm going to skip some of these because I was giving a warning. And the clock, it doesn't want to work. Does this mean just shut off and disappear? Okay, no problem. So in conclusion, what I'm trying to tell you, multi-specialties can work together, and there are actually 12 of us. 2/3 are vascular surgeons, 1/3 are interventional radiologists and cardiologists and vascular medicine, and all reported the old man by the name of Dr. Aburahma. Thank you very much.